Hi, good evening. This is Dr. Vimal Raj from the southern part of India. I'm a consultant cardiothoracic radiologist and the head of the Department of Narayana Health, Bangalore. Thank you very much for joining this very important webinar on the hot topic of COVID-19 and imaging. I happen to be a radiologist who's got special interest in cardiac and chest imaging and have been working closely towards COVID imaging related changes and how things are going to be changing in our life because of that. So today the idea is for me to speak for about 35 minutes and then we'll open this forum for questions and answers, and I will try and answer some of the questions that people have, and we'll discuss some of the burning topics in relation to the imaging of COVID-19. The issue of CT is what we're going to focus on. We are not going to talk about chest radiograph on this presentation. I would be happy for people to just ask any questions as the presentation is going along. Just type in your questions at the bottom of the screen and it'll come to me and I'll handle these questions at the end of the presentations. So the objectives for today are: what is the role of CT in COVID-19? We will discuss some of the guidelines which have come out on the use of CT in COVID-19. We'll also talk about radiology department preparedness. Are you prepared? What are you doing to be prepared for the disease, whether it's a patient who's got suspected COVID or a patient who's got proven COVID? What should we be doing? And in the end, I think this is one of the very important topics that a lot of people have been asking. Can CT be used for screening? Is it a test which we can reliably use to screen patients or not? We'll discuss that also. Now, let me be very honest about it, okay? This is a dynamic situation. As of now, in India, we are nearly reaching 19,000 proven cases of COVID-19. And this is changing by the hour and by the minute. So the evidence which is available today relating to COVID-19 and imaging is exactly same. The evidence that we've been looking at has been changing. There have been papers which have been telling us something, and then suddenly there is another paper which is contradicting what is happening. The RT-PCR testing, the swab test, is available at places and is not available at places. So for example, in some of the institutes, if they send a swab, it is taking up to 2 days for them to get a report, while in other places, it is only a couple of hours that is taking to get the report. So this will also have an impact on whether CT may play an important role or not. Antibody testing is on the verge of becoming very widely available. It is available at some centers, but again, is that good enough or not? We will discuss. And at the end of the day, like with any other writer, this is my personal opinion with quotation of whatever literature is available, and I have tried to be as unbiased as possible in this regard. So, CT chest in COVID. So when you see a CT chest in COVID, or whether you're going to start using or not, these are the important questions that everyone is thinking about. What are the features of COVID in CT? Now, once we know the features, can we differentiate it from other disease entities or not? Third, is it useful in assessing the disease severity? Can it give us an estimation of whether a patient will improve rapidly or whether this patient may go into an ICU setup requiring ventilation? And do we have anything else apart from our acumen and our intelligence to help in detecting and getting these diseases picked up early? We'll tackle one by one these points. Now, these were some of the seminal papers which actually came out early in the disease. When I say early, they are as early as last month, because it's such a dynamic nature of this disease entity that papers are being published every day about them. And these results are alarming at times, and some of them are being published with very little scrutiny in the interest of spreading the knowledge to the wider community. These papers came out in March and February, and they turned around and kind of clearly told us, the paper at the right bottom, which looked at 1,000 cases, they clearly told us that COVID has a specific pattern on CT, where ground glass is the predominant pattern, which is followed by consolidation, some interstitial changes, and then a mixed pattern which will come. These papers also told us unanimously that bilateral involvement and lower lobe involvement or peripheral involvement is much more common. Some of these papers also said that few patients had a normal CT at the time of presentation, but the abnormality progressed rapidly after the symptom onset happened by about 6 to 11 days of symptom onset. The other thing which became very obvious was that at discharge, some of the patients continued to have abnormal CT, although the RT-PCR had become negative and there were no symptoms in the patient, but the chest CT remained to be abnormal. They also looked and showed that patients who had extensive disease on the CT were the ones who did not do well. They were unwell compared to the ones who had less disease in the CT. This led to some of the beautiful pictures which got projected, which got shown to us, showing that ground glass was the most predominant pattern. And within the ground glass, there were multiple other patterns which we came to know. Pure ground glass, as in this case, and then there were ground glass with some interlobular septal thickening. This pattern is something which has become very, very synonymous with COVID-19, where in the ground glass you're starting to see blood vessels which were prominent, so hypertrophy of the blood vessels, and many other publications later on also corroborated this fact. And as the disease went by, there were areas of consolidation that we were developing, and some areas of traction bronchiectasis was developing in these cases. And what you can see here is that the disease happens to be peripheral in nature, and the disease happens to be predominant ground glass. They also shared some beautiful examples. This was a 35-year-old female who got discharged on day 17. And you can see at the onset, there was this ground glass peripheral bilateral involvement and a prominent central vasculature. This is something which I have started trying to look at even my other cases, but it's not very common, and I have not found this in our normal infective cases. Then by the follow-up, you could see that this patient ended up getting much worse disease bilaterally. Then again, further worsening of the disease before the disease starts to improve, where you start to see more of consolidation settling in this patient. A different patient where you can see ground glass changes which were present on day 3 of the presentation, and as it went along, bilateral involvement started coming in. The disease got a bit better, slightly different morphology than what it had presented before, and by about day 17 it got almost gone with some subtle changes left around there, and the patient got discharged on day 20. Now look at the two cases which I've shown you. They both were relatively young patients. This was another case. This was a 63-year-old lady who had severe disease clinically, which required a lot of support, and you can see that the ground glass changes and the involvement of the lung is much more extensive than what we had seen in the other cases. So the elder people were getting much more disease, and the severity of the disease was much more in CT as well as clinically. So there was good correlation between this. Now when we start looking at this, people question and say, hey, can we differentiate this from other forms of pneumonia or not? Or is that just because you are dealing with COVID patients and we are confident and we're going to call this COVID or not? But then more work started coming from Europe and America, and they also started showing something similar. You started getting papers in the RSNA where they came up with a consensus statement about how to report these chest findings, where they showed cases of nodular ground glass bilateral peripheral opacities very similar to some of the other non-ischemic changes like organizing pneumonia that we may see on a day-to-day CTs. When you look at these cases, the question comes very specifically is, how good are we at differentiating these from another cause of viral pneumonia like an influenza or even SARS in there? And this got addressed in this one paper, which basically was a collaboration of COVID positive patients from China with influenza or viral pneumonia cases from America. So the radiologist looked at these cases in together, and they came up with the sensitivity and specificity of saying, let us look at and see what is our sensitivity and specificity to differentiate COVID from one another. The Chinese rats had a sensitivity ranging from 72 to 94% in picking up COVID correctly, while specificity varied from 24% to 94%. While the US rats seemed to do much better with both sensitivity and specificity. The study design was a little flawed. It came for a lot of controversy in there. But what became very clear is that these are three different patients, which we have demonstrated here. All the three were COVID positives. And these were the cases which the radiologist most often did not call COVID. I do worry when we look at these cases because calling this abnormality or this subtle abnormality COVID with any confidence in my day-to-day practice, I will need a lot of guts, or the prevalence of the disease has to be significantly higher if I'm using CT in isolation without the RT-PCR testing. Although the study says that we are very good at differentiating, the sensitivity is high, the specificity is something which worries me, especially when we looked at the Chinese rats. So this comes to the next point where we say, what is the role of CT when we look at the disease severity? Can CT help us in assessing the disease severity? This is one of the few topics in COVID imaging where there is least controversy. Everybody agrees that the CT severity correlates with the clinical severity. And there are multiple papers which have come in, and in real life practice in China, in Korea, in Japan, as well as in America and Europe, people started using different methods of CT scoring. And they also looked at the admission CT, and one of these papers which I've quoted at the bottom where it specifically looked at admission CT and said, can this predict whether this patient will end up in ITU or not? And the answer was yes. Now, how to score disease severity? How do we really score disease severity? This is one of the methods that people have looked at. Okay, this is aided with a little bit of machine learning and a little bit of attenuation correction or Hounsfield unit calculations. So what they looked at is if you do scoring based on the mean lung density, if your mean lung density was less than 816 minus Hounsfield unit, you had mild cases, minor disease. However, if you started having a density of the entire lung, which was a little bit higher, then you started going towards severe cases. And if it was even more than minus 779, these were the cases which were critical cases. Similarly, they looked at the relative volume of the normal lung density. So they clubbed all the abnormal lung volume together and looked at just the normal lung volume and said, how does this compare? The more of normal lung density would mean that the patient did well compared to the patient not doing well. This is one such software which they have used, which is based on machine learning and artificial intelligence, where the machine was able to quantify the areas of abnormality, was able to tell them this is the percentage, and was able to give them a disease severity scoring. A simplistic method, if you do not have any sophisticated softwares, is to basically divide each lung into three parts, upper, middle, and lower. And each part you look at and see how much of that lung is involved. 0%, I would give it a score of 0. 0 to 25%, I would give it a score of 1. 25 to 50%, I would give it a score of 2. 50 to 75, score of 3. And more than 75% of that segment of the lung being involved will give it as a score of 4. So each lung can get a score of up till 12. So overall, you could get a maximum score of 24. So that could be seen as a simple starting disease severity scoring. This has also been looked at, the papers which I have quoted before, and these were shown to correlate very well with clinical progression. So we can look at this score. In the follow-up CT, we can see what happens to the score. Is it getting worse? Is it getting better? So that way it becomes very easy for us to follow up these patients and assess what is happening in the disease progress. Now, there are other companies. This is one such company, which is an Indian company, Credible Health, where I have contributed to some of the work that they've been doing. They are also able to pick up these areas of peripheral opacity, ground glass changes, differentiate between the ground glass and consolidation, and are also able to come up with the percentage of lung involvement and different types of fibrosis, which is very useful in us assessing and giving a score for the same. So this tool is useful also to try and objectify the disease burden and use this in terms of follow-up and research activity. There are many similar products which are available on the web. Some of them are for free, for trial purposes, and some of them do cost us. So, what are the features of COVID on CT? Well, we are very clear that there is ground glass which progresses onto consolidation, which can lead on to fibrosis. These are predominantly bilateral, these are predominantly peripheral in nature, and these tend to involve the lower zones. Can we differentiate it from other diseases? If you believe the literature, yes, but looking at the cases, I believe it can be difficult, whereby in an area where viral pneumonias are not that common, perhaps we can distribute or distinguish these cases, but in cases where viral pneumonia is very prevalent, it may be very difficult to differentiate one type from the other. Is it useful in assessing severity and progression? Yes, it is a fantastic test to assess for the severity and also track the progression of disease. Artificial intelligence softwares are available to help us in quantifying and also screening some of these studies to a much higher accuracy to help us in improving our pickup rates.